everyone. It's my pleasure and my honor to welcome all of you tonight to one of our weekly online series. On behalf of the Educational Board of the Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome the speakers, moderators, and attendees to this creative and prestigious continuous opportunity to deliver not only an up-to-date curriculum in the field of anesthesiology, critical care medicine, and pain, but also to gather unique and speakers and moderators from all over the globe. This opportunity is and will remain a great and successful experience in the current and the future virtual learning, especially during the current pandemic. Tonight, we have a special topic in anesthesia and pain with unique speakers in the field. I would like to welcome Dr. Hanaa Abouelfotouh and Dr. Ahmed Abulatti on the panelist side, and Dr. Makharita, Dr. Yasser Reda, and Professor Mohamed Makharita on the speaker side. Our first moderator is Dr. Ahmed Abulatti. He is currently an associate consultant at Hamad Medical Corporation, Qatar. He is a fellow of the College of Anesthesiologists of Ireland, and he holds a certificate of the Arab Board of Anesthesia and Intensive Care, and also a fellowship in anesthesia from Hamad Medical Corporation. Dr. Abulatti is an anesthesia program coordinator for the Qatar Board of Medical Specialization and the department co-lead of IT services. He's also an instructor in the Airway Management Academy, Qatar University, and Will Cornell Medical College for students. Our second moderator is Dr. Hanaa Abouelfotouh. She's currently a consultant in anesthesia and intensive care in Ministry of Health, United Arab Emirates, and a lecturer in Al Monastir University in Egypt. She has a master, MD, and a certificate of Arab Board of Anesthesia and Intensive Care. Dr. Abulfotouh has a special interest in obstetric and regional anesthesia.
Dr. Ahmed. Yeah, thank you, Dr. Ahmed. A sincere and warm welcome to each and everyone attending today. I'm pleased and delighted to be here with you and being able to meet this wide range of professors and colleagues in this enormous platform. It's my pleasure to thank each and everyone who helped and worked hard in making this idea into this stressful situation, especially Dr. Saad Mahdi. Now I would like to, and I have the honor to welcome Professor Dr. Mohamed Makharita. Dr. Mohamed is a big name in pain medicine. He's a professor of anesthesia, ICU, and pain management, Faculty of Medicine, Mansoura University. He got his master's degree in pain management. His main interest is chronic pain management. Besides all this academic work, he is a general secretary of Egyptian Society of Chronic Pain Physicians. Dr. Makharita will give us today a unique lecture about pain practice during COVID-19 pandemic. Welcome, Dr. Makharita. You can proceed. Thank you.
Thank you, Dr. Hanaa, for your introduction. My talk today about pain practice during COVID-19 pandemic. Pain itself is a serious condition. The body reacts to nucleus stimulus both locally and generally. The local inflammatory reaction constitutes the local response and considered to be important for healing and defense against infection. The general response in the form of endocrine metabolic activation leading to hypermetabolism with an acceleration of the most of biochemical reaction. Myocardial ischemia due to increased heart rate, blood pressure, and oxygen consumption may result in myocardial infarction. Increase in the blood glucose and catabolic hormone may lead to precipitate more infection. Increased coagulability and DVT and thromboembolic manifestation may occur. Both cellular and humoral immunity will be depressed. So, prolonged and exaggerated neuroendocrine response is harmful and increase patient morbidity. As acute pain keeps going for a long time, it becomes centralized. This means that brain starts feeling the pain, and at this point, where the patient starts seeking the help for pain treatment, it becomes very hard to control. Chronicity associated with sleep deprivation, decreased motivation, and muscle wasting and depression, and vicious circle depression with increased chronic pain, and go on. Chronic pain actually a disease entity, and control of pain from the start may prevent the progression from acute to chronic pain. The COVID-19 pandemic has worsened the pain and suffering of chronic pain patients due to stoppage of elective intervention, pain management procedure, and office visit across the world. The objectives of this lecture will be to discuss three questions. What are the problems that face the provision of pain services during COVID-19 pandemic? What are the challenges for reopening the pain clinics and restarting the intervention procedures? How should pain management adapt to this problem? The first question, what are the problems that face the provision of pain services during COVID-19 pandemic? The European Pain Federation, known as EFIC, conducted a survey to assess the impact of COVID-19 pandemic on pain practice in Europe in June 2020. More than 400 pain physicians respond in Europe. And the first question was about the status of pain management services during COVID pandemic. And unfortunately, more than 1/3 of pain clinics were completely shut down. The second question was about what do you do, how can you interview your patient during pandemic? And the answer was like this. Only 4% face-to-face consultation and 51 virtual and telephone consultation. This is the new telemedicine. And both type of consultation was found in 45%. The third question was about the activities and the priority for which patient in the pain clinics. And we found that in pain practice during COVID-19 pandemic, about 40 services for cancer patients and 20 of the services in the pain clinic for complex regional pain syndrome. Only 11% of the clinic do all activities, and other intervention like epidural steroid in 25% for radiculopathy. Neuromodulation like spinal cord stimulation and implantation of a pump constitute only 5 to 10% of the activity in the pain clinic. And about 70% of the consultation through the telemedicine or teleconsultation, and 33% through the video. The fourth question was about the stress due to pressure of the created by COVID-19 pandemic. And we find that this survey found that about 60% of the patient has mild anxiety. 30% of the doctors has mild anxiety, and 30% of doctor has severe anxiety. So we need to support our pain clinic teams to decrease their stress. The fifth question about the percentage of patient survival have been referred to pain clinic with new pain. Notice the question has new pain. So they ask about patient survived after COVID and has pain, what is known as post-COVID syndrome. And by the end of June, only less than 20% of the survivor referred to pain clinic for a new pain. The pain physician must record any pain symptoms in COVID-19 survivor. We noticed more patients referred to our pain clinic in Mansoura University with post-COVID syndrome. We noticed two types of patients suffering from pain after they recovery from COVID-19 infection. First, two post-COVID syndrome, new pain in patient with no pain before. Second type of pain is patient with chronic pain, suffering from more and more pain due to post-infection. This patient, like fibromyalgia patients, suffer more pain, chronic fatigue syndrome suffer more pain, and also patient with back pain suffer more pain due to more exhaustion, increase in the weight, and less activity. The sixth question about medication used during the COVID-19 era and how the physician feel with use of this treatment, and the conflict about non-steroidal anti-inflammatory, steroid, epidural, and opioid. Almost no change in our practice was noticed in this survey. The physician used non-steroidal, steroid, epidurals, and opioid. Problems in the research during COVID-19. Due to need for urgency researches, availability of direct fund and money for urgent researches, and rapid publication, and lack of adequate reviewing, more than 25,000 publications about COVID-19 published by August 2020. This gives rise to uncontrolled report, increased withdrawal, intellectual mess. Therefore, a pandemic is no excuse to lower our clinical standard or scientific standard. A pandemic's scientific urgency should push us to trash out these fake, fabricated, and low-quality publications. Emerging controversies in pain management during COVID. The most famous are two: COVID and non-steroidal, non-steroidal anti-inflammatory drugs, namely ibuprofen, and COVID and steroid. COVID and ibuprofen. The WHO declared to press that there is no adverse increase in the risk of disease with the use of non-steroidal anti-inflammatory in COVID-19 patients, namely the ibuprofen. The WHO recommends its use in patients with chronic inflammatory arthritis, already taking non-steroidal anti-inflammatory as a regular prescription. So there is no relation between increased risk of disease and use of non-steroidal anti-inflammatory drugs. COVID and steroid. Also, corticosteroid-related immunosuppression has not been significant consideration in intervention pain medicine prior to COVID-19 era. Concern about the effect of injectable steroid on immune system are being actively discussed in the intervention pain medicine community now. So before the COVID era, there is no harm to use injectable steroid. Now, the concern about the depressive effect on the immunity arise. The immunological effect relevant to COVID include elevated blood glucose level that predispose to more infection, migratory inhibition of leukocytes, inhibition of production of inflammatory mediators such as interleukin, macrophage, migration inhibition factor, inhibitory effect on proliferation and function of lymphocyte via inhibition of lymphokinase and cytokinase. So, steroid depress the immunity and the immune response. Therefore, clinician practicing intervention pain in COVID-19 era are faced with the challenge of first, how to perform intervention pain procedure with sustainable effectiveness. This is how to perform intervention with long-term efficacy and long duration of pain relief. Second, whether a low dose of steroid or avoidance of steroid is a possibility. Epidural steroid used by pain specialists for radicular pain due to disc herniation, discogenic pain, Field-Baxter syndrome, or neurogenic claudication secondary to degenerative spinal canal stenosis. Given the equivalent evidence of the steroid in treatment and in most of the intervention pain technique, there is equivocal evidence for the efficacy of steroid to prolong the effect of the block. So it is equivocal evidence. Local anesthetic, therefore, local anesthetic with steroid being reserved for patients with significant radiculitis and also failure to respond to local anesthetic alone. So consider appropriate steroid distancing and low than normal dose. Special consent, not only about the risk of epidural. I highlight the suppressive effect of steroid on immunity relevant to COVID are given instruction about the measure for disinfection and protection against COVID virus must be provided to the patient prior to any intervention using steroid. This is an example for a consent in which you inform your patient about the depressive effect of steroid on the immunity and the risk of increased infection with either general infection or COVID-19 with the use of epidural steroid injection. And then give precautions that can protect your patient after this procedure, like avoid close contact and spacing, and avoid touching your eye, nose, and mouth with unwashed hand, washing of the hand, use of alcohol, and disinfectant of the surface and hand regularly. This will protect the patient against the risk of infection with COVID-19 virus or coronavirus. So the new consent in which there is instruction to protect the patient and information of the patient about the risk of epidural and the risk of infection after use of the steroid in this epidural block. The second question to be answered in this lecture is what are the challenges for reopening the pain clinic and restarting the intervention procedures. Social distancing, limited efficacy of the current medication and controversies, restricted hospital capacity due to COVID-19 patients, more than 50% of pain physicians involved in the direct COVID duties, pain physician anxiety and the fear of infection and transmission of infection to their family. All these are challenging in reopening of the pain clinics and restarting the intervention pain services. Moreover, healthcare employee burnout. This burnout is a job stress resulting in loss of productivity and decreased workforce efficacy. And lastly, impending physician and nursing shortage. The current second peak in winter and expected third one in next few months. And with resurgence, the restrictions are once again being imposed. Lastly, the economic impact of COVID pandemic on all community. All these are challenging for reopening of the pain clinic and restarting of the intervention pain therapy. Reopening policy and procedure. After this challenge, we must put a policy for reopening and put a priority for some patient in the pain clinic. So we select the most uh, patient in need for pain services. Those include cancer pain patient, acute emergency like complex regional pain syndrome, acute herpes zoster, acute radicular pain, and spinal fracture. Please consider post-COVID widespread pain issue. This is either true post-COVID syndrome after survival of the patient or worsening of the pain present before infection with COVID, like in patients with fibromyalgia and chronic fatigue syndrome, and patient with back pain, even patient with headache. Their symptoms worsen after infection with coronavirus. This is all the term of post-COVID syndrome or post-COVID pain syndromes. Shielded patients who have been waiting for a long time. We have elderly isolated for a long time and they seek for pain services. Once there is reopening of these services, they are come from their houses and those patients are have not exposed to infection before, so they are very sensitive to the infection, and these shielded patients must be taken into consideration. They carry a high risk of infection with COVID-19 virus. Psychological issue for both patient and health team provider. Depression, burnout, and psychological depression. How can we provide pain services? We must improve our virtual clinics, telemedicine, Skype, Zoom, and through telephone. Encourage self-management strategy. This is very important. This is come from education through the media, television, newspapers, and the, through the media and the telephone, Facebook, and WhatsApp, and like this. Delivery of care through a local or family doctor. Family trust their doctors, their GP. We must increase our GP knowledge about the pain management for COVID-19 during COVID-19 era. Regular virtual meeting for family doctor for advice and medication review. This is very important. And we must put a red flag for urgent assessment and referral to pain clinics. If there is a need for a pain clinic like acute radiculopathy due to disc herniation, not responding to medical treatment, and this is not surgical, like acute herpes zoster. These patients are red flag and must be sent to the pain clinic immediately. We must put a governmental policy on social distancing and personal protection. We must do temperature check, wearing of mask, social distancing, and hand wash to eliminate the risk of infection and make hospital visits safe. Provision of a COVID protected pathway in hospital. This is a green zone for our patient to reach our clinic in the outpatient clinic safely, far from the red zones, attempt to deliver diagnostic and definitive intervention in the same setting. Before we do like in intervention like lumbar sympathectomy, we do diagnostic block and then we do therapeutic block. It is advised during the pandemic to do the both diagnostic and therapeutic block in the same day, and then restrict the use of steroids. Personal protection equipment in the pain clinic is important because the condition of the patient is not known for us. Just we do a telephone interview with the patient before, give an appointment for him to reach the clinic, and we ask about the symptoms of increased temperature and bone ache like this, sore throat, diarrhea, loss of smell, and then we the patient come to us in our pain clinic. We must protect ourselves. This protection is important and must be adequate to provide a full protection for all staff members. Despite the use of these precautions, hospitals have been a very high infection site for COVID spread, and air samples contamination in hospitals area is about 20 to 50% of all places. Office, clinic, ambulatory setting will be a site of concern related to the further COVID-19 spread. Remember, you must do a telephone or video or tele connection with your patient before asking him to come to your clinic to protect yourself and your team. The third question is about how should pain management adapt to this problem. We have a priority in our patient, and we must put a policy for restarting of intervention pain procedure. All of us know that chronic pain patients require high intensity care, especially during a pandemic such as COVID-19. Subsequently, it has become necessary to provide a guidance for triaging and intervention pain procedure during a pandemic. We need to stratify our patient and put a recommendation for intervention pain management during this pandemic. We have a pain stratification tool that provides a guidance for intervention pain specialists and their patients during the COVID-19 pandemic to minimize the COVID-related morbidity while allowing a return to intervention pain care. This is the tool. There is 8 items like age, pulmonary condition, cardiovascular condition, obesity, diabetes or blood glucose, renal function, hepatic function, and immune status of the patient. And for each of the 8 items, we give either for low risk, either 0 or 1, and moderate risk, either we give 2, and for high risk, we give 3, and calculate a score from this table. And the patient with a score less than 7 points considered as a low risk. And this scoring from 8 to 14 points are moderate risk, and high risk above 15 points. So through this stratification, we can stratify our patient either low risk of infection with COVID, moderate risk of infection with COVID, and high risk with infection with COVID. So after this stratification of our patient, we must know our patient status. First, if you know your patient status, either the patient do a PCR 48 hours before coming to intervention pain therapy, and PCR say it is negative, or patient had a COVID before and has antibodies. In those in both this situation, you know the condition and status of your patient, and then proceed with the procedure. If you don't know the condition of your patient, if the patient has symptoms, refer to COVID for testing by PCR and CT scan analysis. If there is no symptoms, your patient either free, normal, or asymptomatic carrier. So in this situation, you must stratify your patient according to the risk factor. If the patient has low risk, this is score below 7, proceed without steroid or with the lowest therapeutic steroid dose. If the patient has a moderate risk, then in this situation, you must balance the risk-benefit ratio and the clinical judgment according to the severity of the pain symptoms. And you may consider delay for COVID testing by PCR. If the patient has a high risk to develop COVID-19 or have a high risk of COVID-19, delay the procedure and for further investigation. Through this stratification and these guidelines, you can select your patient for appropriate intervention with low risk of infection of you and your team. Real stories from pain unit in Mansoura University. This patient has cancer head pancreas and serum bilirubin was 14. As the patient referred to gastroenterology center for insertion of stent and by AOS. And during insertion of the stent, our colleague did celiac plexus block. Unfortunately, it was unsuccessful and the patient suffered from severe pain. Therefore, in spite of giving medical treatment with a block, there is continuous pain. Therefore, they referred the patient to our pain clinic in Mansoura University. And we did splanchnic neurolysis using alcohol with a very good result, and the patient pain come down and the patient become able to sleep with in addition to giving him medication, and we started to withdraw the medication and decrease the dose of opioid, and the patient quality of life improved. The second case is complex regional pain syndrome. Look for the drop wrist. This patient suffer from complex regional pain syndrome for 4 months and come to our clinic with suspicion of paralysis or thoracic outlet syndrome, and we diagnose the patient as complex regional pain syndrome. The patient receive appropriate medical treatment in addition to serial of stellate ganglion block. She had 3 successful weekly apart stellate ganglion block. Unfortunately, this stellate ganglion block, in addition to the medical therapy, improve her condition, and now her hand like this, and then we send the patient to the physiotherapy to complete her treatment. Another case of sympathetic mediating pain, another drop hand. But notice, this patient has injury here. And the surgeon suggests it is injury of a deep branch of the radial artery associated with cutting of the tendon of the extensor tendons, and send him to our pain clinic, and we did the stellate ganglion block. Fortunately, when stellate ganglion block improves his condition 100% because this pain was sympathetic mediating pain, and just we interact this sympathetic mediating pain with the block, the response was dramatic. The third case was about Ramsey-Hunt syndrome. This is a facial herpes zoster associated with facial palsy, and we did two sympathetic blockade for the face, stellate ganglion block, with successful improvement of the patient condition, including hair pain, facial pain due to herpes zoster, and also his neurological function in the form of facial palsy. This is a case of radicular pain due to L5-S1 disc prolapse. Notice the disc here, the foraminal narrowing, and the patient suffered from L5 and S1 radiculopathy. We offered him L5 and S1 selective nerve root with very good result and his improvement of his symptoms. After discussion of this acute and high priority case in our Mansoura pain clinic, our home take message is chronic pain patients require a continuity of care during the time of COVID-19 pandemic. Pain specialists should optimize telemedicine evaluation of the patient before face-to-face consultation. This is for protection of you and your team. Clinician must assess patient, local health resources, and weigh the risk and the benefits of the procedure against the risk of suffering from disabling pain and exposure to COVID-19 virus. Pain specialists should take steps to evaluate risk-benefit of intervention pain therapy on a base of case-by-case basis, hoping to apply science to our life. Thank you. This is my...
Okay, the first question from Shahid Hafiz. How can we manage acute and chronic pain effectively in this pandemic in the remote, rural district where resources are very limited?
Yes. For acute pain and chronic pain through the pain clinic, you must assess your patient through telemedicine first. And when you are sure he is clear from the virus, you can face-to-face interview of the patient with take all the precaution to assess your patient, and then you put a plan for treatment, including both medical treatment and intervention pain treatment. Put in your mind that local anesthetic is a priority for intervention pain medicine, and if it is a radicular pain, you will put the smallest amount of steroid available, and also you must exhaust all treatment modalities like self-massage, heat application, and TENS before going to do intervention during the COVID-19 pandemic.
Okay, thank you, Dr. Makharita. I have another question from Mohamed Abulatti. Do you encounter post-COVID chronic pain?
Yes. Mansoura University has a clinic for post-COVID syndrome, and pain management will be a part of this clinic. We have two types of post-COVID syndrome. First type is pure post-COVID.
Voice interrupted, Dr. Mohamed.
We have two types of patients. We have two types of patient in post-COVID clinic. First type is patient with COVID syndrome, true post-COVID syndrome. Those patients come with bone pain, muscle pain, headache, and other type of pain. But the most important is the other patient who have chronic pain before, and after recovered from COVID, he suffered from more pain. Those patients include fibromyalgia patient and chronic fatigue syndromes. So those patients suffer from severe agonizing pain because the quality of life of those patients is very bad from the start, and they need exercise, they need to go out the home, but now they are trapped inside the homes and can't do can't do exercise and like walking in gardens and like. So we have worsening of the already present chronic pain and new pain in COVID syndromes.
Okay, Dr. Makharita. We have you have a special greeting from Dr. Mohamed Abulatti. Is your trainee before? And we have another question from Mohamed Sulaiman. Do you think that non-pharmacological method of pain relief can play a role during COVID-19 pandemic?
Of course, this is a chance for non-medical massage, exercise, tense machine, and all other yoga, meditation, and all other form of non-intervention treatment and non-medical treatment is important in this era.
Thank you, Dr. Mohamed. This was the last.